So we will talk about hypovolemic shock. Now, hypovolemic shock can be due to significant blood or fluid loss. Intravascular volume is reduced, either due to blood loss or due to fluid loss. Okay. Now, depending upon the history, the causes can be divided into two types: hemorrhagic and non-hemorrhagic. Non-hemorrhagic hypovolemic shock may be due to diarrhea, vomiting, sweating, burn, hypothermia, etc. And hemorrhagic shock is loss of blood volume, and it is mostly due to your trauma, bleeding, right? So hemorrhagic and non-hemorrhagic shock. Now, hypovolemic shock, as I told you, what are the causes? Causes of hemorrhagic shock. Causes of hemorrhagic shock can be external blood loss due to any wound, trauma, exteriorization of internal bleeding, that is hematemesis, melena, your epistaxis, hemoptysis, massive blood loss, right? Internal bleeding, internal bleeding which is not coming outside, but there is a bleeding like splenic rupture, right? Any internal organ hemorrhage. Traumatic shock due to trauma. Patient is in because of a trauma, wound, anything, there is a huge loss of blood. Non-hemorrhagic shock, digestive losses, vomiting, diarrhea, nasogastric suction, biliary, digestive fistula, etc. Renal losses, diabetes mellitus, polyuria caused by diuretic overdose, osmotic substances, polaric phase of ARF, etc. Skin losses due to intense physical effort, exertional heat stroke, then third space loss due to peritonitis, your pancreatitis, ascites, pleural effusion, so loss of fluid in the third space. So these are the causes of non-hemorrhagic shock. Okay, what is the ATLS classification of hemorrhagic shock? So blood loss is classified by Advanced Trauma Life Support System into 4 classes: class 1, class 2, class 3, class 4, and management depends upon the class. Urgency depends upon the class. They are classified on the volume of the blood loss, on heart rate, on blood pressure, on pulse pressure, on respiratory rate, urine output, and central nervous system. So depending upon the blood volume loss, how much blood volume loss is there? If it is less than 750 ml of blood loss, that is less than 15%, right? It is class 1. Between 750 to 1500, 750 to 1500, that is blood volume loss of 15 to 30%, it is class 2. 1500 to 2000, that is 30 to 40%, class 3, and more than 2 liter of blood loss, it is class 4. So less than 750, class 1, 750 to 1500, class 2, 1500 to 2 liters, class 3, and more than 2 liters class 4. Now heart rate, less than 100, class 1, more than 100 but less than 120, class 2, more than 120, class 3, and more than 140, class 4. Blood pressure, in class 1 and class 2 blood pressure remains normal and decreased in 3 and 4. Till class 1 and class 2 body compensates. 3 and 4 decompensation happens. Pulse pressure normal in class 1 but decreased in class 2, 3, 4, right? Respiratory rate 14 to 20, mildly tachypneic. 20 to 30 in class 2, 30 to 40 in class 3, and more than 35 in class 4. Urine output, in class 1 patient maintains a urine output more than 30 ml per hour. In class 2, 20 to 30 ml per hour. Class 3, less than 15 ml, 5 to 15 ml per hour. And class 4, urine output becomes negligible. And CNS status, Patient in class 1 is slightly anxious, class 2 is mildly anxious, class 3 is anxious and bit confused, and class 4 is stuporous, that is lethargic, confused, stuporous. Patient is stuporous. Okay, so end organ damage has started happening. CNS function is deteriorating, right? Okay. Now, what is pathophysiology of hypovolemic shock? In pathophysiology of hypovolemic shock, remember, because of hypovolemia, venous return decreases and preload decreases. Hypovolemia, venous return decreases, preload decreases, then cardiac output decreases. Cardiac output is equal to stroke volume into heart rate. So when preload is reduced, cardiac output is reduced. Cardiac output, blood pressure is equal to cardiac output's total peripheral resistance. So when cardiac output reduces, hypotension happens, perfusion reduces, and because of hypotension, perfusion failure and tissue hypoxia, which leads to organ dysfunction, which results in multi-organ failure. So preload reduces, cardiac output reduces, perfusion reduces, end organ damage starts, and multi-organ failure, patient goes into multi-organ failure. So we have to stop at the level of preload, decreased cardiac output. We have to resuscitate so that preload, we are able to maintain the preload. We have to prevent hypotension to happen, and we have to prevent the perfusion failure to happen. So we have to start the resuscitation immediately. So in hypovolemic shock, what would be during assessment? What are the clinical signs? Patient is anxious, patient is dizzy, alternate mental status, CNS symptoms. Patient is thirsty, patient is pale in hemorrhagic shock, cool, clammy skin because of inadequate peripheral perfusion, then delayed capillary refill time, then tachypnea, tachycardia, weak thready pulse, and wide pulse pressure, hypotension, decreased cardiac or urine output. All these are features of hypovolemic shock. That is, all these features are because of end organ dysfunction. So CNS dysfunction, mental status deteriorates, patient is anxious initially, later on becomes stuporous. Then hemodynamic parameters, that is patient has delayed capillary refill time, patient has decreased blood pressure, patient has elevated pulse pressure, patient has decreased urinary output, patient has a rapid thready pulse, skin is cool and clammy because of poor perfusion. So all are because of poor perfusion, right? So immediate action we have to take. These are because of poor perfusion, organ dysfunction is happening. So we have to stop it. We have to take immediate dysfunction. Whenever the perfusion becomes poor, the patient starts becoming stuporous, CNS deterioration happens, other organ dysfunction starts happening. This will increase the problem of the patient. This will further deteriorate the problem of the patient. So after seeing the assessing the patient, we have to take the action. And as I told, as in any emergency medicine patient, primary survey, initial stabilization, ABC. We have to go for airway, breathing, circulation. So we have to see airway, breathing, circulation. Now airway of the patient is stuporous, patient is comatose, we have to secure the airway to prevent any aspiration. Patient is tachypneic, work of breathing has increased, maybe we will have to support the ventilation of the patient. Circulation, we have to assess the circulation and we have to intervene. So what are the intervention? After assessing ABC, we are assessing ABC, and along with assessment we are going for the interventions. I maintain the airway and breathing, give oxygen and keep the patient warm, right? Have the person lie flat with feet elevated if no contraindication is happening, right? If there is no contraindication of lowering the head and elevating the limb, I am trying to increase the cardiac output, right, by increasing the venous return of the patient. So I make the patient lie flat with feet elevated if there is no contraindication for this. Now airway has been stabilized, breathing has been stabilized, I have made my patient warm. Now I will put 2 wide bore cannula and start giving warm crystalloid fluids. Initially, we give 1 liter of RLNS or 20 ml per kg body weight to assess the response. We try to maintain the intravascular volume through crystalloid, and if it is not maintaining, we can go for blood. We can go for blood transfusion. So blood and blood products must be infused earliest possible in a bleeding patient, in transient or non in a bleeding patient, right? And in patient who is not responding to crystalloid. If patient who is actively bleeding, right, we have to give the blood and blood products. If patient is not responding to the crystalloid, non-responders, again we have to use blood products. We need to activate massive transfusion protocol. If we have a transfusion protocol in our hospital, we need to activate it. So we have to activate the massive transfusion protocol if indicated. What is this massive transfusion? When we have to activate this protocol? So what is the definition of massive transfusion? Massive transfusion is defined as transfusion of more than 10 units of blood in 24 hours or more than 4 units in 1 hour. Right? If I give more than 10 units in 24 hours or more than 4 units in 1 hour, we call it massive transfusion. Right? Now, early resuscitation with blood and blood products in low ratio is recommended in patient with evidence of class 3 and class 4. So class 3 and class 4, we go for a blood and blood products resuscitation, right? Patient with severe shock resulting from trauma can present with or develop coagulopathy from blood loss. So dilution from large volume of crystalloid fluid resuscitation. So in these patients, in let's say massive trauma patients, they may develop coagulopathy from blood loss, and if I give a lot of crystalloid to them because of dilution, coagulopathy, or because of hypothermia, they can go into coagulopathy. So if patient will go into coagulopathy, there is huge, again there would be a bleeding disorder, more blood loss will happen. So there is always in class 3 and class 4 early resuscitation with blood and blood product is recommended. Okay. Now, what is massive transfusion protocol? Profusely bleeding patient in class 3 or class 4 with an expected blood loss greater than 30% of the blood volume may require a massive blood transfusion. In these cases, massive transfusion protocol should be activated by the treating doctor, and steps should be taken for early definitive control of hemorrhage. To ensure timely availability of blood and blood products, blood bank is activated and alerted, and early administration of PRBC, plasma, platelets to minimize the crystalloid administration in these patients may improve the survival. Okay, you're getting my point? So blood and blood product must be infused at earliest possible in bleeding patient, right? In bleeding patient, actively bleeding patient, in non-responders who are not responding to crystalloid resuscitation, blood product should be given as early as possible. Now, massive transfusion protocol has to be activated. Massive transfusion, what is this massive transfusion? Massive transfusion is defined as more than 10 units of blood given in 24 hours or more than 4 units given in 1 hour, right? Now, early resuscitation with blood and blood products is indicated in class 3 and class 4 hemorrhage, right? Patient in severe shock can go into coagulation disorder, coagulopathy, due to massive crystalloid, right? They can go into dilutional coagulopathy if I give a huge amount of crystalloid to them. They are also very prone to hypothermia, so they can go into coagulopathy because of hypothermia. So in these patients, we have to give warm blood and blood products immediately to stop this dilutional coagulopathy, and because of coagulopathy, again a blood loss can happen, right? So in class 3 and class 4 hemorrhagic shock, we need to activate the massive transfusion protocol of the institute. Now, what is this massive transfusion protocol? Again, I am repeating the same thing, that profusely bleeding patient in class 3 and class 4 may need a early resuscitation by blood and blood product. So if I am expecting greater than 30% of the blood volume to loss, active bleeding is happening, patient may need a massive blood transfusion, right? In these cases, a massive blood transfusion protocol is activated by the treating doctor, and steps should be taken for immediate and early control of the hemorrhage. A massive transfusion protocol is activated and steps are taken to immediately stop that hemorrhage, ongoing hemorrhage. When massive transfusion protocol is activated, the blood bank is activated and blood components are made available by the blood banks, right? The early administration of PRBC, blood products, plasma, platelets, and minimizing the crystalloid is required in these patients. Then only the survival will improve. So this is what is massive transfusion protocol, right? Class 3, class 4, we have to give blood products and try to stop the hemorrhage. Blood bank is activated, products are made available, and crystalloid resuscitation is minimized, right? Now, a large prospective trial has demonstrated the role of tranexamic acid, tranexamic acid, if given within 3 hours of trauma, has improved the survival in the patient, right? When 1 gram dose is given in pre-hospital setting, patient has been given roadside by the emergency medical services who went there to pick up the patient, right? They gave, let's say, tranexamic acid, Trenexa they had already given 1 gram. And again in emergency department, 1 gram of Trenexa can be repeated, right? So role of Trenexa has positive role of Trenexa in controlling the bleeding. So it is administered. Now, early monitoring of coagulation and replacement of the clotting factors can minimize the transfusion needs, which is particularly important in patients who are taking anticoagulants medication. So old age patients on anticoagulant. Now, early recognition of the coagulopathy can restore the clotting, and restoration of the clotting factor can minimize the transfusion needs in these patients. So thromboelastography and rotational thromboelastometry are two monitors which are helpful, and when they are available to pinpoint exact coagulation abnormality, deficiency, which factor, which part, which of the intrinsic and extrinsic pathway is deficient, from where the coagulation disorder is happening. They can be exactly determined, known by thromboelastography, and it is let's say determined by thromboelastography, and exact clotting factors are replaced, right? Now, resuscitation with fluids and blood is not like we are trying to resuscitate the patient, but it is not substitute of let's say continued blood loss. Blood loss is happening and I am resuscitating the blood with blood. Well, this cannot go on for a long time period. So definitive management has to be kept in mind, and we have to stop the cause of bleeding. So any internal bleed has to be diagnosed fast, identified fast, and has to be stopped. Aim is to have a early control of hemorrhage. The bleeding from external sources are easily managed by pressure technique. Direct pressure on the wounds may stop the bleeding, like scalp wound, etc. Scalp wound bleeds a lot, but if you apply external pressure, you do a pressure dressing, it will stop the hemorrhage. Internal bleeding may require immediate surgery. Bleeding from the long bones may require immediate stabilization of the fracture bone, right? So definitive management is stop the cause of bleeding. Stop the cause of bleeding, right? Other management is to restore the volume. Restore the volume. Immediate management is to stabilize the airway, breathing, and try to restore the volume till the definitive management is done. So this is how we manage a hypovolemic shock patient. Okay.